Hello and good evening, dear students. I am Dr. Ruchi Raj. I'm your prosthodontics mentor at DBMCI, and I welcome you all to this beautiful series of previous year questions by DBMCI targeting INI-CET November 2025. We begin the session and the series today with prosthodontics. And very good evening to all of you. I welcome all of the students that are attending the session here. Good evening. Let us keep this interactive and get the best use out of this particular session. So, very good evening, Komal, Sami, Tanvi, Alia, Shubrat, Swati. Very good evening to all of you, and I welcome all of you to this particular session. This is a series that has been started by DBMCI where we cover the most important previous year questions in a 1 hour session. This is a way to identify what are the most important previous year topics, learn the important facts about them, and this in a way helps you solve the majority of questions that come from that subject in the exam. We are starting this particular series today with prosthodontics, and the series will continue until up till your INI-CET for all of the subjects. So stay tuned for the entire session. We'll keep the discussion for 45 minutes and we'll have a good interactive question and answer session in the last 15 minutes. Also, I have a very important announcement for you at the end of the session. So stay tuned till the end, right? Very good evening, all of the students that have joined. Now, it is about 8 to 3 and we have about 66 students joining. So that's an excellent number. And I welcome all of you. We'll wait till about 8:05. See, majority of the people have joined. Very good evening, Dr. Bhumika, Shriti, Lakshita, Rashmi. Very good evening, everyone. And I welcome all of you to this particular session. Now, before we kickstart with the specific MCQs and the topics, I'll just advise you one thing. Try and focus on what we are trying to teach in that particular moment. You can always reference to the video later on to make notes, and let us keep the session interactive. If you have any questions for me, you can always share them in the comment section and I'll be most happy to solve them for you. Right? So, very good evening, all of my students. Okay, Tanvi, is the voice clear now or is it still lagging? You could just try and reconnect through the session and see if it is better for you. I have not seen similar complaints from other students, right? So I hope everything is fine, audio, video, everything is clear, right? So all good. All of the students now who have joined with me live for the first time, you all can just say hi, first time, first, and we'll try to keep the session better for you and try to keep some interaction going between us. Right. So very good evening to all of our students. We have a very good number to begin. Now let's start the session. So prosthodontics in general, I remember on Teachers' Day also a lot of students said that this is one of the subjects that they don't particularly like during BDS, right? It is a very vast subject. The preclinicals were very tough. Now, how to tackle a subject like that? So let us just see an overview of what has been asked in the past 10 years of paper. Now, the general format, if you see for NEET or INI-CET, is how much I'll tell you. There is a particular set of previous year topics from which even new questions come. And the idea here is that if we tackle those previous year topics, then we would be able to answer those newer questions with much more confidence also in exams, right? So that is the whole gist of it. So from Prostho now, this is the overview slide that I want you to remember. These are one of the most important topics specifically for INI-CET. That is occlusion, incomplete dentures, in general, anything about occlusion. Main concept about vertical dimension, VDO, VDR, centric occlusion, and its different recording mechanisms. From partial denture, I would say it is mainly about the design, the components and its indications. So what component is used where? That is the main, I would say, area to be learned with. Now, when we go to FPD, it is about the different materials that are used in FPD, the margins that we use with them, what quantity is used where, where veneers are indicated or not. Very specific. Like in veneers, we've seen mainly indications are asked always, right? For post-space preparation, how much space is needed, etc. Right? For crowns, you can see different finish lines, etc. Right? So all of that. Now, impression materials, techniques, generally block out is asked, retraction is asked, tracers are asked, all of that is asked. And from implants, we can see specific numerical values being asked. Now, students, up until now, were you able to follow? Are you able to follow up until now? Is the audio clear, or is the issue for everyone or just a few of you? I would want to just get a head start from you. Is the audio clear? Yes, Sammy, this topic is for INI-CET. I have specifically mentioned it for INI-CET, but it is applicable for both. Now, let us start with the first most important topic, right? Very good evening, all of the students. Extremely happy to see that we have about 90 students joining in for the session. Now, for those students who feel that there is a lag or something, you can just get out and join back on the same link. I'm sure the issue would be sorted for you. Now, all fine? Okay. Let us take up and tackle the first most important topic, which is vertical dimension of occlusion and its related complaints. Now, vertical dimension, a very important part of jaw relation. And what I have seen in the past 10 years is either something related to recording vertical dimension, something related to the methods, or something related to the after effects of a wrong vertical dimension of occlusion is asked. So either the related denture complaints or something related to the concept of VDO. Now, we have done these sessions before also, where I have described Facebook and other similar important topics also. Just so that repetition does not occur, I have not included those topics today, but you can always go back and refer to those topics again also in the previous videos that I had done last year and the year before. Now, let us tackle what is vertical dimension of occlusion. We have one representative MCQ. What is it? A complete denture patient complains of muscle soreness after wearing dentures for few hours. This is due to what? So what the patient is saying? Patient has muscle soreness after wearing dentures for few hours. This is due to reduced interocclusal space, excess muscular force of the patient, excess force exerted by the patient to retain the denture, or increased in occlusal space. Now, I'll teach you two, three things here. First, the theory. Second, the technique to solve such MCQ. Right? And before we go into details, I want to highlight something very important. Frequency of any question in relation to vertical dimension has been 9 times in the past 10 years. That is almost every year it has come either in the November or the May session. And you can even see the list here. This is the entire list. So something that involves the concept of vertical dimension. So the whole idea here is that if you're aware of these topics and if you master them, these are all your cash marks for your exam, right? So our effort here is to make you aware of these topics, master these topics and keep them in your pocket for cash marks. We are assuming that maybe next or even the next paper, something would come out of it because it's a very important topic, right? So now understand this particular question. What does it say? A complete denture patient complains of muscle soreness after wearing complete denture for a few hours. It happens due to what? The correct answer here is reduced interocclusal space. Now let me explain the concept to you. All of us have a particular vertical dimension. This is a vertical dimension that we generally measure between two anatomical landmarks such as the tip of the nose and the tip of your chin. Now, what that vertical dimension is? It is the separation between jaws. That is what your definition says. Now, all of you that are sitting right now, I'll ask you to do one exercise. Swallow and close your mouth. Do it alongside. Swallow and close your mouth. When you swallow and you close your mouth, your jaw goes up. And there was some space that was present between your jaws. Now, before you swallowed, The position in which your jaw was, that was the rest position of mandible. The space that was present between both of your jaws, that is your freeway space. And now when your teeth are in occlusion, that is vertical dimension of occlusion. So the equation that forms here is vertical dimension at rest is equal to vertical dimension of occlusion plus freeway space. So for example, in my patient, I have measured this as 60 millimeters. Then, knowing the theory that I should at least keep 2 to 3 millimeters of freeway space, I have to adjust the video at around 57 to 58 millimeters. Now remember one thing, vertical dimension of rest cannot be altered. It is always fixed for a particular patient, depends on a lot of anatomic muscular factors. But VDO is something that we set in a patient, or we have to obtain and arrange or settle in our patients. That is something that we give in a particular prosthesis. So different methods are there. Phonetics is there, aesthetics is there, then there are other several techniques by which we evaluate first what is VDR. Then we start adjusting our video in a way that we get a freeway space of 2 to 3 millimeters. And then we correlate and check it via phonetics. We can ask our patient to say different words that have supposedly the sound S, that is the closest speaking space. And we see that space during function. That is how we settle it. Now, what happens if we don't arrange this freeway space to its desired value of 2 to 3 millimeters? Supposedly, this is 60 and this is 60 millimeters. Now, imagine the gap that is there between your jaws is not there and you're constantly holding your teeth. Try and do that. Supposedly, your teeth are always in contact. So, alongside me, you have to hold your teeth in occlusion continuously for say next 2 minutes. What do you feel? The first thing that you feel is muscle soreness. You don't feel TMJ pain that comes at a later stage. The first thing you feel is muscle soreness. So that is what is happening when we don't give the freeway space. The teeth will constantly be in contact because there is no freeway space in between. And that is how the muscles will not get its desired rest. And the patient will come running to us with the complaint of soreness as early as even after 24 hours also. So the effects of increase and decrease in vertical dimension are extremely important from exam point of view, and either they are asked in form of VD or in the form of a question that is case based and in terms of troubleshooting in complete dentures. So our first and very important topic for exam is this vertical dimension of occlusion surrounding this. All of our 106 students right now, have you followed? Can you give me a thumbs up very quickly? Can you give me a thumbs up very quickly? Now, one of our students, Lakshita, has asked why D is not the answer. D means what, Lakshita? That instead of these values, you have, suppose this is 60 millimeters, this should be 2 to 3 millimeters ideally. But instead of this, you have kept it 6 millimeters. So this automatically becomes 54. Now there is a lot of space between your jaws. So what will happen? For example, if the upper jaw is here, lower jaw is here, and this is the amount of space that should be there. So the patient closes like this, right? Suppose that space is this big. Now the patient has to close this much. So what will happen? Overclosure of mandible. When overclosure of mandible happens, the patient will feel that I'm like an edentulous person only. Itna मुंह क्यों बंद करना पड़ रहा है? It should have reached at the correct point. Now the patient is overclosing the mandible. This patient will complain that my teeth are dull. I'm not able to bite through my food. And there is a lot of space visible through my between my teeth when I'm speaking. So it looks as if I don't have any teeth only in my mouth, right? So that will give more of like an edentulous appearance, wrinkles around the mouth and all of that, right? So yes, we have all of these answers. That is a very good question. Let us move ahead now to the next topic from partial dentures. You have understood, and let us move to the next question now. Now, next question. Generally, in partial dentures, I'll tell you one thing. Attend our sessions. understand the core concepts behind partial dentures, and then I think within those 6 hours of session that I take in my life for partial dentures, at the end of it, every single one of you can design a cast partial denture. I guarantee you. If you understand the concept, you will design a cast partial denture at the end of the session with me. Come blank, at the end, all of you will design CPDs. If not, I'll even tell you how you can do it in a small amount of time at the end of it. Now, from that scenario, the very important question that comes from partial denture is clasp systems. Which clasp to use where? Now tell me very honestly, have all of you felt till now that you are not able to follow through which clasp is to be used where? Just let me know in the comment section here. Are you still confused? Do you feel that I don't know which clasp is to be used where? Do you feel something like that? Be honest, it's okay. And I have a very honest uh, what do you say, thing to share with you. I think during my graduation days, I also did not know which class to use where, even probably through my internship also, I used to be also very confused. So it is a very confusing topic. Now let me break it down for you first. What is important? So RPD, specifically all class systems and their indications mainly. That is very important, right? What is the frequency of this topic? 9 times. All of these papers you can see here, multiple instances. These questions have been asked here. A lot of cases here where students are saying, right? So even I used to face these issues. It's okay. But let us try and understand. Now let us see a representative question. Which of the following clasp assembly is shown in the figure on the tooth number 3, 4? So this particular tooth here, what is the clasp assembly? Now let us have a look. What do we have? A mesial rest, looks like a proximal plate and looks like a Y-shaped approach arm. So this mesial rest, proximal plate, I bar or even a Y bar is suggestive of an RPI system. So RPI stands for what? RPI stands for, let us keep an eye on the comments also, mesial rest, proximal plate, and an I bar, right? So as you can see in the image here, there's a mesial rest, a proximal plate, and an I bar here. So this is an RPI. Now, I'll even tell you all the other components also. This is your standard circumferential clasp. You can see this is a C clasp, right? This looks like a lingual bar. From the top view, definitely looks like a lingual bar. This is a mesh type of a minor connector. So this is a mesh work, and this here has been added as an indirect retainer. It's an auxiliary rest. Don't get confused. I have kept a question of indirect retainer, so I'll explain you later on. Yeah, I am sorry. I think maybe when I move, the voice might echo a little. So I apologize. I'll try to be in one position, but please bear with me. Actually, there's a lot of music going outside because of Ganpati Visarjan, but let us focus on our session. Now, so I hope you were able to identify the clasps. Now let us understand indications of clasps, right? So all indications of clasp systems, just remember, tooth supported, generally, I'm saying generally, we prefer C clasp. I'm saying for tooth supported, we generally prefer C clasp. Tooth supported, generally we prefer C clasp. And for tooth plus tissue supported, generally we go for all of the infrabunch variety. So we will have RPI, RPA, I class, Y class, all of that. Okay, Nikhil is asking, how is it lingual bar? See, Nikhil, just from how it looks like, I'm assuming it could be a lingual bar. It could also be a sublingual bar also. But since there is no sheath or apron of metal here, it's definitely not linguoplate. It is not on the cingulum, so it is not even cingulum bar. So it could be sublingual bar or it could be lingual bar, but it's either of that. Now let us come to our topic here. So for tooth supported, we go for generally C clasp. And for tooth tissue supported, we generally go for an infrabulge clasp, right? That is how we routinely follow for these kind of indications of cast partial dentures. So just remember that if you want to understand the detail of it, I can take up a small video or a session where we can explain you better which class is indicated where and what is the why behind of it. Or you can always refer to my videos. But just remember it for now that for distal extension cases and tooth tissue supported, we prefer infrabulge clasp systems. Tooth supported, we generally go for circumferential clasp. So RPI, that is rest proximal plate I bar. RPA is rest proximal plate Akers clasp. These are the different systems that we generally prefer. So from partial dentures, you can have these indications, or you can have these components, or you can have identification through image based question. That is what comes. So for partial denture, I always would advise our students, go for a concept based study, understand the reasoning behind it, and you will never forget it. You will be able to design partial dentures very effectively and answer every question pertaining to it. Now let us come to question number 3. So thumbs up. Are we good to go ahead, students? So let us check our questions here. Anjali, RPA is rest and proximal plate remains the same. A is the C clasp of a circumferential clasp. Instead of I, we have the Akers clasp over there. That is RPA. Now, let us come to the question number 3, again from RPD. Again, a very important topic. Now, this is something that I've seen is generally overlooked. A lot of students feel Kennedy classification is not important, Applegate rules are not important. And if this question comes in exam, most likely you will take it very lightly. But this is where majority of students will make mistakes. Now, look at the frequency of this. Almost 8 times in multiple of these papers. Kennedy classification Applegate rule is something that is absolutely very important. It helps us in day-to-day OPD communication, jotting things down on our case paper. It should come very naturally to you. Kennedy's classification, that is how well you should know it, right? So Kennedy's classification, extremely important, and easier topics like these, and which is where we make mistakes. Now let us take this question. Identify Kennedy class of partial edentulous arch after applying Applegate rules. And what is it? We have an edentulous space located anteriorly, straightforward. It is Kennedy class 4. Now, this I'm dead sure all of you would be knowing. Now, I will give you a situation and I want you to classify for me. For example, this tooth was missing here. In this particular situation, apart from the edentulous space anteriorly, this tooth was missing. Please write down the classification in the comment box. I would very quickly 10 seconds type in into the comment box. What should be the classification for this? Now, what classification does this become? When there is a molar missing like this, does this become class 4 mod 1? Is it class 4 mod 1, students? Class 4 mod 1? Okay. So, when we now scroll through the comments, we get to know that there are students amongst us who have some confusion regarding this. So let me try and explain. Applegate's rule has mentioned it very clearly. The most posterior edentulous space is going to be the one determining the classification. And then all other number of spaces will be registered as modification space. Now, out of both of these, most posterior is this one. And it is a single edentulous unilateral space. This becomes class 3 and this one area gets added. So it becomes mod 1, right? So this becomes class 3, mod 1. Now, class 4 cannot have any modification space because if there is any, it will be posterior and automatically it will change the classification. So remember these rules. Now, as a tip here, I'll tell you something. Remember, this classification is in Roman, modification is in our standard 1, 2, 3, 4 numerical. Sometimes it may be possible, class 3 mod 1, just the nomenclature would be written differently. And at that point of time, you may be thinking कि तीन option एक जैसे थे कोई भी एक लगा दिया. Something like that, right? No, you have to know the correct nomenclature, how it is written also. So just a small tip here, but try and remember it, right? So Kennedy's classification, again, a very important topic, has come almost 8 times in the past 10 years of paper. And hence, something that you should always keep in mind. Now, this is to fixed partial dentures, but before that, students, are you able to follow through? Are you enjoying the session? Is it going too fast, too slow, helpful for you? We'll just take a small pause here. And if there are any queries also, you can always put them into the chat box and let me know. I'll be very happy to solve those queries for you. Yes? So, all of our students, yes. So just give me a thumbs up. If you all are following it, we can go ahead, right? So a lot of students are now saying yes, yes, fine, excellent. Finish lines for crowns. Again, a subsection from fixed partial denture from which a lot of material science can be explored and turned into questions. Now, again, let's see what's the frequency of this. 8 times. So this means what? Questions related to materials can come, questions related to finish lines can come, questions related to their angles, design, indications, anything. This one topic has a lot that can be asked, right? So let us see. INI-CET May 24, November 23, November 21, November 22. That means repeatedly, at least in the last 3 years. What does this suggest? This suggests that this is an important topic and something that you should always learn and remember. There is one big topic, one big daddy topic, I would say, of FPD. I've not included in this session because probably every session I've taught it is Pontics. So you can go back to my PYQ sessions done before and Pontics, Facebook, shade matching. Three very, very, very important topics, irrespective of NEET, INI-CET, any exam. I've explained them plenty of times before. That is why I've not included in today's session. But it is not that they are not important. They are extremely important. You can always refer to those videos also. Now, let us check here. One representative question. Finish line for an all ceramic crown should be what? Shoulder, chamfer, heavy chamfer, sloped shoulder or shoulder with bevel. This is a kind of question that gains a lot of controversy also. If I say the answer is shoulder, student will say, why not slope shoulder? Why not shoulder with bevel? So with this question, I'll teach you one trick to solve MCQ. And the trick is what? Your answer should satisfy the majority of what is asked in the question. So when they state all ceramic crown, can sloped shoulder or shoulder with bevel used for all of the all ceramic crowns? No. But can shoulder be used for all ceramic crowns, all of them? Yes, absolutely. Right? So it should be able to cover the entire umbrella, not just one specific indication. So remember a line always while solving MCQ. If they want a specific answer, they'll ask a specific question. If a general broad question is asked, generally a broader answer would be there for it. Remember this. If they want a specific answer, yes, someone has written A is much greater than B. Yes. If they want a very specific answer, they'll ask you facial margin of buccal surface of this particular tooth, what kind of a finish line. Means they are looking for something very specific over here. But a broader question like this, nothing about anterior, posterior, all ceramic, which material, nothing is written. That means dead sure the answer is shoulder over here only. So this is something that I wanted to teach you because I know all of you know metal is what chamfer, ceramic is what shoulder. I know this much, all of you know. Then why should I keep this question? Firstly, because it's very important. Secondly, this is something that you should be aware. Now, let us very briefly and quickly have a look at the reasoning behind it. Now, you need to understand one thing. Metal as a material is very strong, and in smaller thinner sections it can be burnished means it can be burnished here and adapted very well. So even 0.5 mm thickness of metal is sufficient, but on the other hand, ceramic as a material is brittle. It requires bulk for that strength and to counteract that brittleness. That is why we give this thickness of margin over here. So prostho and DM are related like this. Because of the material properties, the different kinds of treatment protocols or how we do certain things in prostho are going to be followed. So since ceramic is a brittle material, we need a wider preparation for it that will support the material, right? Now let us come very briefly at this particular table. Feather edge, chisel edge, generally not recommended, but if there is a tilted teeth, probably we will go there. Now we have a student who is asking shoulder with bevel is what? The core concept behind bevel is to remove unsupported enamel. So when you have a facial margin of posterior metal ceramic crown with supragingival margin, you want to remove that unsupported enamel, go for beveled shoulder, or any kind of beveling is generally to remove any unsupported enamel. Apart from that, just remember this: metal, chamfer, and ceramic shoulder. Now, if you are a student who has not done a single crown preparation, this is just theory for you because you have not applied it in practically in patient. So how do you remember? The C and C both together are not friends. So ceramic and chamfer are not friends. They go opposites. That is why metal is with chamfer and ceramic is with shoulder. Just try and remember these kind of things. Right? So that is how this particular question needs to be tackled. Right? So we were at question number 4. Let us come. We have almost come halfway to the section. So one of our students is saying, ma'am, please take morning motivation sessions. I am trying to work my way through it. Actually, the timings are clashing with some of my other obligations, but I'll definitely try to make my way through it and guide all of you to excel and go study at AIMS New Delhi. That is probably the best reward a teacher can get is you go study in the same department where once I had studied. It's almost 10 years since I joined there, but I'm very happy if one of my students goes and studies in the same department. So, students, we are almost halfway. And give me a thumbs up if you have followed everything. Do you have any doubts for me here? Any doubts, any queries, any questions, any suggestions, anything that you want me Pratishta, okay. At the end of the session, I'll definitely summarize all of those important topics for you. I'll give you 5-7 topics that you take it in a way as a takeaway that before the next session happens, I'll revise and learn those 5-7 topics. So this is also a good thing all of you can do. You can follow the series and before the next session starts, you learn these important topics. That is how up till your INI-CET, automatically in a scheduled timetable fashion, you will be covering these important topics, right? Now let us come to question number 5. So, palatal tori, exostosis, genial tubercles. I've included all of those bony projections into one thing only. And either the genial tubercle will come in exam or that buccal exostosis will come or the torus will come. So let us discuss everything about it today. Almost it has come in the recent papers 4 times. We can see in 23, both of the papers actually, 22 and 2019. Let us understand it and see where it comes from. Patient comes for complete denture fabrication. His palate has a torus extending, very important word, till the junction of hard and soft palate. What will you do for this complete denture? Make a hole in upper denture to free the torus. Line the torus with a soft liner. Provide relief in the area of torus for retention and stability whenever possible. Or you will just straight away go for surgical excision in all of the cases. Now, students, here I want to tell you something, the reasoning behind what to select the answer. First, you should know this. 4 questions related to torus. If the size plus location of the maxillary torus, we are talking about maxillary torus here, okay? So if the size of the torus, whether it is small, whether it is large, and the location has not been mentioned, very easily go for the conservative option. Conservative means anything that is apart from surgery. Surgery is a much more invasive option. Why? When nothing has been written about size, when nothing has been written about location, just it is written there is a torus present in the center of palate. For example, it is only 2 millimeters. How can you go for a surgical option for such cases? So, questions like these that require more information, go for the wider option that can be applied to all of them, right? Go back to that same thumb rule. Is this answer applicable to all or everything that is asked in the question? And then select that particular. Now, for example, in terms of location, it is mentioned till the hard palate and soft palate junction. So, till the hard palate, soft palate junction, if it is mentioned, but size has not been written, what will we go for? Just relief. And if the size has not been mentioned, even if it is small, but it is beyond this junction, you have to definitely go for surgery. Now, let me explain over here. A lot of students are mentioning surgical excision. Why? Because I've seen in particular some question banks answer given for this question is surgery. But let me explain. When the torus is only till the hard and soft palate junction, it does not interfere with your PPS. The PPS can be achieved easily, specifically when the size of the torus has not been mentioned. But the moment the torus crosses that junction, even if it is small, you cannot have a seal on an elevation. You have to remove it. Even if it is small, that elevated bone, you cannot develop a PPS seal over it. So you have to remove it. So the general rule here that you remember is nothing about size and location is mentioned. Go for conservative options such as relief. If it is only till the junction of hard and soft palate, go for relief. If it is beyond the junction of hard and soft palate, go for surgery. Again, in terms of location, if it is small, then relief. If it is large, and the question describes that it interferes with function, patient has cancer phobia, patient feels that he has malignancy, there is no way that you can establish C. All of these are suggestions to go for surgery. Now let us come to our question. Never make a hole. You are breaking the seal of the denture, so don't make a hole. Lining the torus with soft liner cannot help you. The correct answer is to provide relief in the area of torus whenever possible. Now, why have I not selected option number D? In all cases is written. Surgical excision of torus to aid in retention stability in all cases. If there is a very small torus, will you go for surgery? No. So you have to see whether your answer satisfies every situation and then go for it. Yes. So what Subiksha is saying is absolutely correct. If PPS is hampered, you are not able to establish a peripheral seal. You will have to go for removal of that particular torus or go for an alternate treatment plan. That is, place 4 implants, go for an overdenture, something else, go for fixed prosthesis, go for an alternate treatment plan or go for surgical excision. So that is how we tackle your tori. So I hope tori is clear. So students, write torus and give a thumbs up. See, these are the indications of it. Extremely large tori. Torus that extends beyond the posterior dam area. See, the indication also has it. Very traumatized mucosa. Now, one-time traumatized mucosa, will we remove it? No. When the question mentions patient comes with repeated trauma over it, matlab, आपने relief दे दिया, but it is not working out. Now we need to find the next solution for it. Or very deep undercuts, it is interfering with function, or psychological reasons like malignancy, phobia. Then you go for torus removal. So I think now all of you should not have any confusion with torus. Let us go to the other section of it, the genial tubercle thing. 73-year-old patient wearing complete denture for the past 10 years complains of pain after wearing the denture now. So 73-year-old patient, the first hint, that patient is significantly old. Wearing denture for 10 years, matlab already significant resorption would have happened. Oral examination reveals lingual mucosa overgrowing over the ridge. What will be the reason for pain? In this region, the patient is complaining of pain. Sometimes even numbness is present, paresthesia is present. What are the options? Alveolar ridge resorption and mental nerve paresthesia, excessive ridge resorption and exposure of genial tubercles, psychological issues, or fracture of denture at some part. Remember, mental nerve is somewhere here. Genial tubercles are the first one to get exposed. So, exposure of genial tubercles is where the patient complains of these kind of things. So, this is also one bony exhaustosis that which you need to remember. Now, what are the giveaway points of it? For genial tubercles exposure, remember, either the patient will be very old or the patient will be long-term edentulous. Okay? Wearing dentures is 10 years, 15 years, 20 years, all of that. Or some bony projection on ridge. Bony projection on ridge. All of these complaints are suggestive of genial tubercle issue. Right? Now, Mahima is asking if there is not present all cases, then should we go for answer number 4? I think Mahima, you are asking about palatal tori. No, I would still suggest, because it is written only till the junction of hard and soft palate, go for relief. When it is suggested that you are not able to establish a peripheral seal, it is interfering with function, anything out of this is written, then go for surgery. Some hint of the indication for surgery should be there. Then you go for surgery, right? Now, this is about your genial tubercles. I think this should be clear for a lot of students. Genial tubercles and your torus and the concept behind it. Pratishtha is saying Vikalan scoop. Yes, very good actually. Pratishtha, you remember Vikalan scoop. So for all our students who don't know, Vikalan scoop published an article to identify the original height of mandible, and where if this distance is x between the mental foramen and the base of the mandible, it is assumed that the original height would be 3x. Again, I think I've discussed this in our sessions before. It is suggestive to check the amount of resorption through an OPG. It's very good to see our students actually remembering topics and related topics also. That is how studies should be, that you should be able to relate the topics. Now, one more thing, although I think time does not permit, but I'll still just touch upon it. Exhaustosis in buccal vestibule, maxillary buccal vestibule. So, just hear me out. Very briefly, I'll just touch upon this, right? Buccal vestibule, that means take your index finger, put it in the buccal vestibule, in the most distal part. Supposedly behind the tuberosity or near that region, there is a bony outer growth and an undercut is forming over there. If the undercut is bilateral plus bony, problem what happens is, it is like this. Now when the denture enters, धक्का मार के एक बार घुस तो जाएगा but निकल नहीं पाएगा. What happens? It will irritate this tissue over here. धक्का मार के भी नहीं घुस पाएगा if the bony bilateral undercut is there, because the denture will not be able to enter. Our material is rigid. Denture is made out of rigid acrylic. The bone is also hard and rigid. How will be it will be able to go through that convexity and reach into that undercut? Not possible. Or even your cast will break. The very good indication of these undercuts is जहां जहां कास्ट टूट जाता है डेंचर बेस बनाने के टाइम पे, मतलब वहां अंडरकट था. Remember it as a clinical term. Bilateral boning, you have to go for surgery. Unilateral, then try to use the undercut. If not possible, try to reduce it in a way that you can utilize it for retention. So that is regarding it. Now, let us come to question number 6. Yes, remove both of the undercuts if it is bony in nature. Now, a simple fact-based question, but why have I included here? When I was going through the papers, I saw it at least 3 times in the past 10 years paper. And it is a simple fact-based question. And on top of it, the answer will not give away very easily. Like wo naam, terminology, by those things, you won't be able to figure out what exactly the answer is. So just very simply remember here, porcelain artificial teeth will not bond with acrylic because both are different materials. Remember the teeth that you use in your clinics, in your postings are acrylic teeth. They will bond with a chemical bond through the acrylic denture base, but porcelain will not. They are different materials, they don't chemically bond. So, how do you retain them? By making something over here, a slot like this present over here, which are called as diatoric holes. Diatoric, even I was not aware of this. I got to know this, I think, in my post graduation only. As a student, I did know this. Or maybe during MCQ preparation, I got to know about this because we never saw porcelain teeth during our final BDS years. We only used acrylic. So, porcelain artificial teeth bond with acrylic denture bases via making diatoric holes. There is no chemical bonding or no fusion or no cyanoacrylates. So, just remember a good fact based question. If I was an examiner and I want to segregate the students who have not read PYQs, I'll put questions like this. And the students who make mistakes in PYQ will make mistakes over here and they will be segregated towards the end of the rank lot. So always remember, if you want the top ranks, not a single mistake in PYQ should be there. So remember this question from your complete dentures. Now let us come to implants. With implants, Shika, let me take up your question towards the end of the session. We'll start up with implants here. So I hope I'm not boring all of you. You're finding the session interesting. And let us now discuss something about implants. Keep the session interactive, keep the session lively. Put in your queries, your questions, or anything that you want to say for the session also. Now, with implants, I understand and what I've seen through the past 5-6 years is the toughness has increased. On the toughness scale, it is increasing thoda, it is increasing. Earlier, very basics were asked. Now they have come to socket shield and even beyond. Let me tell you one simple mantra for it. Read CD, RPD, FPD, maxillofacial occlusion very nicely. For implants, do the basics that we teach in our classes. If anything is beyond that for it, remember it. What is new for you is new for everyone, and not a single of you is implantologist or someone who has a practical experience of implant. So they will also find it difficult and they may make mistakes in that question. So you have to give that much leeway to yourself. Remember, so for implants, it is a very vast topic. Even today also, I try to learn newer things about implants because it is an ever evolving segment of prostho. So my strategy, if I were a student in today's time, would be learn the very basics and whatever has been asked about implant, and then leave whatever is absolutely new. You can't run behind it. What is new for you would be new for every other student. Now, what are the basics? For implant, spacing, dimensions, distance from other teeth, 7 times it has been asked. So calculate the distance for this implant or what is the distance available here or numerical questions, right? So let us take this particular question. See the amount of years that this has come. And apart from 2016 November, all of them have been in the recent past 2, 3, 4 years only. So implants is increasing definitely. Now in the space shown below, in the image shown here, what is the minimum space required between two remaining teeth for the insertion of two 5 millimeter diameter implants. Let us do the mathematics. 5 millimeters plus 5 millimeters for two implants. Now we have to adjust this distance between the implant and the tooth. So that is 1.5 and 1.5. And the distance between the two implants is 3 millimeters. So 3 plus 3, 6, and 10 equals 16 millimeters. So that is a correct answer. Number 16. So remember this fact here. Distance between natural tooth and an implant that you're supposed to place is 1.5 millimeters, and between two implants that you're placing is 3 millimeters. Now, there's a reason why I've written it like this. Sometimes we have a visual memory, and a lot of students get confused and think between the tooth and implant is 3 and they reverse it. When we have a visual memory like this, we might be able to remember it better. So space out that implant one. Try and remember that that distance is larger and bigger. It is 3 millimeter between the tooth and implant is 1.5. So these are small, interesting ways that you can apply to your other aspects of study also and make it easier for yourself, right? So this is the representative image. This distance here 1.5, 1.5, and this here is 3 millimeter. Now there are other numerical questions also, such as distance between the implant in one arch and the occlusal surface in opposing arch. What is the minimum distance required? Again, question is asked minimum distance. Just write it down. It is 8 millimeters. So minimum distance required between the surface of implant in one arch and occlusal surface of the opposing arch is 8 millimeters. So for implants, till a very long period of time, such numerical questions used to come in exam. So try and learn them. They are your basics, right? So students, I hope you are able to follow it, all of you. And we'll move to question number 8, which is the segment or topic that I want to tell you is troubleshooting incomplete dentures. Now, as a student, there are two topics in final university exams that we used to exclude: phonetics and troubleshooting incomplete dentures, because nobody used to ask long questions or short questions from it. The same two topics are the most favorite topics for NEET and INI-CET, your FNV sounds and troubleshooting. Now, if you want to see me discussing phonetics, you can go back to my previous sessions of PYQs, and I have discussed it in one or either session. That is why I've not included it today. But for troubleshooting, there is a very good article that is published in BDJ, and I've shared it with our students also. In fact, when our live class comes, I'll share it back again with you. Very beautifully, it has described all of our troubleshooting questions and what is the reason for it. Let us discuss one segment of it, that is patient coming with pain. Now, first look at the frequency of it. Almost 4 to 5 times in the past, 4 5 papers, and more importantly, these are case based scenarios. Now, with INI-CET, you have to understand one thing. INI-CET focuses more on case-based questions, or questions where you're problem solving or maybe coming to deducing an answer out of a situation. It is not very factual. So such topics are very favorite of examiners in INI-CET, which is one is troubleshooting. Let us take up a representative MCQ. Complete denture patient who was recently delivered the denture presents with an erythematous swelling mainly in the vestibule of mandible and other areas. It is most likely due to now recently delivered. Remember this erythematous swelling, and it is present in the vestibule. Allergy from the acrylic, overextended area, improper cleaning, or poor quality of mandibular bone. Now, as a student, I'll teach you one technique here how you can cancel out things. When it is already written recently delivered, it is erythematous and present in the vestibule. Now, ideal scenario is that when you make a denture, in the history and examination only, you should have checked whether the bone quality is poor or good or not. If it is genuinely a very poor bone quality, you would have not gone ahead with the treatment only. So I'll cancel this out. This can't be the answer. Recently delivered denture, patient चाहे तो भी इतना गंदा नहीं कर सकता है. So improper cleaning can't be. Now, allergy from acrylic and overextended area in the denture. Now I'll help you how to reach to our answer. It's very specifically written, swelling mainly in the vestibule and other areas, but mainly in the vestibule. If the denture has been inserted into the patient's mouth, the patient would have gone through all of the other treatments also. If the patient had allergy, it would have come at the stage of custom tray, at the stage of jaw relation, at the stage of trial also. Acrylic allergy, okay, first can be a sensitization, but on the second instance it would have come. अभी तक एलर्जी नहीं आया, अब अचानक कैसे आ गया एक्रिलिक से एलर्जी? ऑलमोस्ट द कंपोनेंट्स ऑफ कोल्ड केयर हीट केयर आर द सेम ओनली. सेकेंडली, swelling is present, not redness. It is mentioning erythematous swelling. Focus is on the swelling. Supposedly, if it were written, patient's entire mouth is red, that looks like allergy reaction, right? So I'll cancel that out also. And actually, because of an overextended border, you will get an erythematous swelling. So that is how we can even deduce and come to our answer. Anjali, I hope I have solved and answered your doubt why allergy is not correct for it. So remember, vestibular pain, overextended area, right? Again, I'll give you a very small note to remember. Pain is in the vestibule, or soreness is in the vestibule. It is overextension normally. Pain is along the slope of the ridge. These slopes. Reason is what? Deflective occlusion. Just remember this. Deflective occlusion, I've explained it in our detailed videos also. When there is a deflective occlusion, the denture base will shift like this. It will be unstable. It will shift. And when something shifts like this, it will cause friction on that slopes. Supposedly, there's a denture over here. Now imagine this denture is constantly shuffling like this. What will it do? It will cause soreness over here, right? So deflective occlusion can lead to an unstable denture. Remember, in the very basics of complete denture, the single most important factor for stability is occlusion. When we have deflective occlusion, denture is unstable. Matlab, it will move like this and it will lead to pain on the slopes of the ridge. And when there is in the vestibule, it will be overextension. So I hope, again, a very good differentiation between occlusion and overextension is something that you would have understood in troubleshooting, right? Now, let us come to again a very important concept, indirect retainers. See how many times it has been asked. Almost 5 times. So students, it is almost 9 o'clock. I'll take about 5-7 minutes more. The session will be stretched a bit. I'll apologize for it, but it's good actually to be around you all and discuss all of these questions and make you understand it in simple terms, right? So indirect retainers, see, almost 5 times it has been asked. Now, function of indirect retainer is to prevent rotation of denture along which axis. Okay. Very simply, I'll explain you something. Your distal extension cases like these. Okay, you have to imagine here and keep your entire focus on the screen with me for the next 2 minutes. Imagine you have a distal extension RPD in your mouth. This distal extension RPD is present in my mouth. Okay, my posteriors are missing. Now, whenever, and this is the side view that we are seeing, this is the side view of our patient. Are you all doing it? You have to imagine it. Okay, now imagine very nice dairy milk eclair I'm eating over here. Every time I'm eating that dairy milk eclair, on the opposing arch there are teeth here, and that eclair is sticking here, that eclair is sticking here. Now our textbook will not write eclair, our textbook will write sticky food. So imagine you are eating sticky food, and every time it does this mastication, it will lift the denture like this. It has to lift the denture. It will try to lift the denture. when the forces of dislodgement increase and go beyond the point of retention, this particular RPD will have a tendency to flip out of the mouth like this. So this RPD in our condition will flip out like this, will flip out like this. So the whole logic of indirect retention is what? If you put a stomach over here, this seesaw movement is avoided. That means if the denture has a particular component or a stopping point, this entire arc of rotation or this entire arc of dislodgement cannot be completed, because the moment it starts, there is a point over here where it stops, and then that point will keep it in hold and hold the denture in position. This phenomenon is indirect retention, and there are some components that contribute to it. Most likely, it is by placing an additional rest on the opposing side of this fulcrum line, and that additional rest is called as an indirect retainer. Now, one guru mantra that you have to remember is any particular plane, the bisector of that plane is the axis along which rotation would occur. Now, all of this we are visualizing in which plane? This sagittal plane. This is our sagittal plane, right? Mid sagittal plane or our side view of the patient. What is the bisector? This is the bisector. Hold the pen. How does it rotate? Like this, like this. Downwards, upwards, downwards, upwards. So towards the tissue, away from the tissue, towards the tissue, away from the tissue. Is this not the movement? Towards the tissue and away from the tissue. So mid sagittal plane, this is our horizontal axis along which this movement is happening, right? So let us see what is the axis around which it occurs. Rotation that occurs is away from the tissue in posterior extension. That is our correct answer. So mid sagittal plane, this is our axis along which the movement is occurring. I should actually change up this option. Rather than horizontal, I should write say longitudinal here so that it does not create confusion. So longitudinal axis, because horizontal is the axis of mid sagittal plane. So rotation away from the tissue in posterior extension, or rotation in the sagittal plane along your horizontal axis. That is the function of your indirect retainer. Of course, I've explained the concept here in a hurried manner in 5 minutes, but I've taken it up in very detailed manner in our classes also. So that is indirect retention. Let us come to your question number. I think this was, yes, question number 10. I've made a number mistake here. So now this is something that I've added from the recent times. In the recent papers, I have seen implant components are being shown. Specifically the recent one that we use, not the dated old components. Even this is what we saw in November 2024. This is a 3D printed tracer, a 3D printed intraoral tracer, right? So similarly, a question like this has come in the exam. So what we will try to do is, we'll try to incorporate majority of these kind of images in our sessions so that you're familiar with these procedures and these different components. Like for example, in this case, what we see is an impression here. You can see the impression surface, and on this, you're able to see these slots. These slots are able to give away that this is an analog. And now the impression is ready to be poured. Of course, you have not done these procedures, so you will not be able to exactly follow what it happens. But when we have a closed tray implant impression, we attach the analog over it and then we pour up the impression. So the correct answer to this question is an implant analog. But the reason for me sharing it over here is, in the recent papers, I have seen that such image-based questions are coming. So we will, in our upcoming sessions, try to familiarize you with these kind of components. But the basics you should be knowing, which is healing abutment, closed tray coping, open tray coping. Just Google it up, see different images, see different impressions, and maybe when you see it 3, 4, 5 times, you will be remembering it. Now, as a clinical tip, I can give you something. Make a folder of these, save it in your phone, just brush through it once, or maybe once in a week, or twice in a week. You would be able to remember that, right? So, with this, I have actually come towards the end of our session. And before we conclude, I actually want to make you aware of a series, or rather a course that DBMCI is starting. It is Revision Pro version 3. These are the different features of it. And if you thought that the last 1 hour was helpful for you, you can imagine if you're learning Prosto for me within 5 or 8 hours, probably you will be able to cover everything. I think 8,000 or something is a very small amount to pay for almost 19 subjects. So if you have not joined, you can give it a try and see for yourself whether this works for you or not. Whether you go for it or not, remember you are our students. We are always there to help you. You have any doubts, any queries, or any suggestions, we are always welcome you all with those. You can connect with us on our Telegram and our groups, and we are happy to solve them for you. Now, I'll pause it up at this point, and I see there are no existing queries from our students. It is actually very heartwarming to see from the starting till the end of the session, we have a strength of 100 students. That is good bunch of students trying to learn and read well for the exam, right? So, Arshi, yes, my live session is going to be starting in this particular month, and we'll see all of our students over there. Now, last 2 years only, Sami, we started about 23, all of these series. So, you have last 2 years data that you can watch on YouTube. Now, I see that there are no existing queries. Yes, Pratishta, I would say vertical dimension, Facebook, indications of all components of partial denture, Pontic, shade selection, implant values, astringent concentrations of your. This also I've discussed in our videos. That is why I didn't include here. And whatever we discussed today. If you still forget it, you can check it out on Instagram. I think I have shared it as most important topics for NEET. You can just Google Dr. Ruchi Raj. You would be able to find my Instagram. I've made a post for most important topics. Just go through that post, see those topics, and you would be able to find it. Now, with this, I think we come towards an end of this session. As a small request, I'll ask all of you, once the session ends, please do post your feedback in the comments of this particular video. Come back and again watch these videos. If there are any questions, please post them. I'll come back whenever possible and solve them for you, right? So I am ending the session over here. I hope it was fruitful for all of you. I wish you all